we have Dr. Prasanna Venkatesh from Tiruchi. He will be presenting on micropulse lasers.
AV team, can I have my slides? Yeah. Is the AV team there? Yeah, thank you. Yeah, so we'll have a quick slide-based discussion on micropulse. So I have no financial disclosures, and these are two of our cases. So you can see one is a right angle, primary angle closure, moderate stage, patient on 3 glaucoma medications and tablet Dimox, 0.7 cupping and 42. We'll come back to this, and this is again another patient on maximum medical therapy, IOP of 42. So let us come back to these cases in the end after the micropulse discussion, as Murli sir rightly pointed out, how we can have the micropulse for seeing eyes. So these are the objectives that I'll be covering in this talk. So obviously, as sir covered in his talk, traditional CPC destroys the ciliary body and decreases aqueous production, and it is an indication for refractory glaucoma. And now we are moving towards other procedures. Like when we use a continuous wave, as you can see in this video, there is so much of pigment dispersion, there is so much of pupil getting shrinkage, right? The thermal energy you can see in this arrow that I am pointing out. See how much the pupil is actually getting drawn towards that thermal energy. So we were doing a lot of pigment dispersion, atrophic bulbae or phthisis bulbae, and it was like a bullet in one of these kind of, in this particular video, as you can see on the left hand side. So how much of pigment dispersed like a bullet, right? So a lot of these can be avoided, and complications like hypotony, macular edema, is it really worth it? So the urge led to a rediscovery rather, where there was, so where there is a resurfacing of the micropulse that came from the 810 nanometer diode, which was used for the retinal lasers. Similarly, now you can see versus the micropulse for the retinal lasers, how the spots are very sub-threshold. So sub-visible threshold treatment was happening in retina, and that is something that we used for the glaucoma as well, whereas we minimize the thermal damage, and the continuous waves are actually broken up into a micropulse. So just like the phacoemulsification duty cycle, where we have the on phase and the off phase, right? Similarly, the continuous waves were broke into micropulses. As you can see on the bottom, I placed the continuous wave. Pulse is on for only 0.5 milliseconds, and it is off for another 1.1 milliseconds. So that's what micropulse brought into the picture. And I think I'm having some connectivity issues. Yeah.
Don't touch the table.
Yeah, I'm trying my best to not touch the table. Yeah, so there is an MP3 probe compared to the G probe that happens with the traditional CPC. So with the MP3 probe, you can see that now we have the bunny probes, but talks are going on and the companies are trying to give us the previous probes, which was slightly different to this bunny-eared probes that we have. And you have to use a coupling fluid because the coupling fluid prevents energy loss. We need to avoid energy loss, and the procedure operates on 2000 milliwatts. Some people prefer 2500 milliwatts or 2000 milliwatts, and 80 to 90 seconds, 1 eye per setting is the way forward with peribulbar anesthesia, which is quite common. You can also use a vasoconstrictor eye drops and avoid viewing on 3 o'clock and 9 o'clock position. The concept of duty cycle is very important. We had the on and off cycle, and as I told, it's a sweep movement that you need to do, avoiding the 3 o'clock and 9 o'clock position, and it is a ease of use. The learning curve is actually very minimal, and 1 or 2 sittings in a wet lab and you can easily go in and start it. And you can use always a toric marker to mark the patient to avoid the 3 and 9 o'clock, because there is some amount of cyclotorsion from the sitting and to the supine position which may happen, and you may inadvertently treat the 3 or 9 o'clock position. So this is my favorite one, the mechanism of action. So this is what the mechanism of action is all about. I just simplified it to know how the machine works so that you can titrate the machine according to you when you are able to see that the results are not working the way it has to. The circumference of the eye is 52.9 millimeters, and we have 12 clock hours. So we have 12 clock hours. So 10 clock hours are treated, 2 clock hours are not treated. And in the 10 clock hours, if you see, 1 clock hour is 4.41 millimeters because the total eye is 52.9 millimeters. So we are going to treat only 10 clock hours. So we are going to have a path length of only 44.1 millimeter. The probe diameter is 700 micrometers. So if the 700 micrometer probe is going to traverse a path of 44.1 millimeter, this is what we get. 44.1 divided by 700 micrometer, that comes to 63 probe locations. So exactly 63 probe locations locations are the one that we are going to traverse, and it goes to physics, right? Energy is equal to 2000 milliwatts, rather the power, into duration, that is 60 in the inferior quadrant, 60 in the superior quadrant, and the duty cycle of 31.3. We saw the on and off. So a cumulative energy of 100.16 energies are what we are targeting. And if you are going to treat 63 probe locations, then for one probe location, the energy that is going to be dissipated is 1.57 joules. Why it is important is in the next slide. So at 2000 milliwatts, you get at 1.57 joules. So what happens at 1.57 joules is, this is the video, my dear friends. You can see that there is a small amount of movement, but it's enough to actually cause the movement in the trabecular meshwork as well, or a cytoskeletal remodeling that going to happen after you have done this procedure. So what happens when you increase the energy? See, at 1.57, why 1.57 or why 2000 milliwatts is, it is at that point you will get the trabecular meshwork motion movement. If you have it less than 1.57, rather 1.25 or 0.9, there is no red graph at all. That means there is no movement of the trabecular meshwork. And why not more than 1.57 or rather not more than 2000 milliwatts is, if you move it more, or rather if you are increasing the energy more, the tissue recovery doesn't happen. Whereas with red, you can see that there is 100% tissue will actually recover. But with the other one, right, 2.35, or if you are going to use more energy, the tissue recovery won't happen compared to the 1.57 where the tissue recovery happens. This is another example of more energy. If you are going to use more energy, look how much the movement is. The movement is more exaggerated and the tissue may not recover, and it will move towards a continuous wave mode. Whereas if you use very low energy like a 0.08, you can see that even in a microscopic level, the movement is not expected, and even in zooming it even more, you can see that it's only a very microscopic movement which is not enough to cause the action to take place. So right, coming back to the hemisphere or quadrant, it's up to you. You can be an hemispheric approach person or a quadrantic approach person. That's your choice. Post-operative, it's more like what you do with a cataract, a topical steroid. A cycloplegics is very important, and glaucoma medication should not be discontinued immediately. That is something that is very important. And slowly taper your medicines if the IOP is going less than 10, and gauge it accordingly and then do the tapering. And retreatment can always be done, but not less than 6 to 8 weeks. That is something which is very important. So once you understand the physics behind it, that's why I broke up the mathematics and gave it, those are my own slides, where you can see that at the end of the day, you're using the same energy. 1200 to 1500 for a continuous wave is almost equivalent to this, but you end up having lesser complications. You can see that again, energy is graph I've given you, 120 joules in a continuous wave compared to 126 joules that you're using in a micropulse, less pain, less inflammation, and almost near minimal complications as possible. We try to maximum to avoid moving into the redder zone. When you move more into the red zone, that is by increasing the 2000 milliwatts to 2500. If you feel the patient demands it, then you will be moving more towards the continuous wave. Care has to be kept in mind that we'll have to hit the green zone. Sometimes different patients may have different green zones. Maybe we need an additional sweep, or maybe slightly titrating your energy from 2000 to 250 or 2500 milliwatts. Always retreatment is favorable because it's a favorable safety profile and it's a non-incisional procedure. So we started with cases like these: avoid blebs, avoid scleral patch graft areas, and these were some of our initial data that we started in 2018, 2019. When we started slow and steady because we didn't know how to go about it. These are some of the data. We started with only one hemisphere. Then slowly we moved into two hemispheres. And the IOP drop is very good. It's up to 30 to 35%. And there are many pearls, like the secondary glaucomas you can take into consideration. And I'll not go into the details of it. The IOP reduction and the success rates are very promising, and clinical evidence shows it's safe, durable, and versatile. This is something which is very debatable, primary, or is it too early to say? Studies are showing that patients who are having visual outcome, good vision, as Sir pointed out in his last slide, if this is the only procedure that is safe, I think we can go ahead and start with this as well. But we need to know the fair share of complications that is reported. Drop in visual acuity, we have seen patients with cystoid macular edema, and these are some of the ones that are published in literature as well. So the journals are also saying that the human equation is one that is something that we need to master, because there is no audible Q, and the mechanism of IOP reduction is not very convincing. It's not foolproof. So we need to be more concerned about the human equation. Sometimes we need to know what works best in our hands, and this is not the only solution. This is something that is there along with the other things. Yeah, and there are many studies which says that there is a lot of efficiency, and I would like to point one study by Murli Ariga sir et al, and he's also coming up with another paper with a new probe, 89.1% surgical success at 3 months, and AGM reduction of 2.8 from 3 to 2. So that's a significant number. Dr. Satyan sir has also come out with another one of his own. And coming back to the first slide that I showed, so this is the first patient where the patient was treated, and the patient had a spike after 3 months, and then we had to go ahead and do a trabeculectomy. And this is the second patient where the patient's IOP was brought to 24, and after 1 month again a combined surgery. So this is one procedure we feel that it is something that is going to be more like working for refractory glaucomas or secondary glaucomas. You can bring down the pressure. If you need, you can go for a retreatment, or you can also follow up the patient with an additional secondary filtering surgery or a tube surgery. So we'll have to see with more RCTs where we stand. And once again, I would like to thank my mentor for giving me this opportunity to share the data on micropulse, and which is very promising, and it also falls under the armamentarium of MIGS. Thank you.
Thank you, Prasanna, for your wonderful talk. Before we have the small discussion, anybody has any specific questions to ask? Anybody has questions? Okay, thanks all the speakers for your wonderful talk. Just a few comments on the micropulse. Basically, we had a very good results to begin with the probe type 1, and then we had the second probe. Somehow we didn't see a good results with the second probe. So after a long debate and discussions with the company has again come back with their first probe. So I think it is available. The first probe is again available now. If any of you want to really use it, you can go ahead and use it. So the results are quite good in open angle glaucomas, or even in angle closure glaucomas. There is no specific thing, but we are concentrating on the primary glaucomas. Secondary glaucomas with a lot of distorted eyes, it really may not be very good enough. But then again, when you are using it in the congenital glaucomas or the juvenile glaucomas, one has to be very careful, because there's always going to be a rebound. So we don't see much. Definitely there is going to be a retreatment is really required. And again, in the adult glaucomas, if you really look at the paper, there are at least 2 or 3 times we may have to really do that. So retreatment with the micropulse is definitely a thing that we'll have to remember. So is there any questions? If we don't have anything, then we'll, I think the next session is going to be there. So thank you so much, all of you, for being with us today for this IC. We'll have a small photograph. Yeah.